Thank you for joining for this presentation. The ACT test unveiled, a game changer for precise hearing aid amplification in noisy environments. My name is Ashley Hughes, and I'm an audiologist at Interacoustics US. I began working at Interacoustics just over 4 years ago, but have been practicing in a variety of settings for over 10 years. Prior to joining Interacoustics, I first worked clinically, then I worked as a research audiologist for a hearing aid manufacturer, and then I joined Interacoustics in 2020. In my current role at Interacoustics, I provide support, education, and training on all things audiometry, impedance, OAEs, hearing aid fitting, verification, and telehealth. And of course, with that now comes support and education on ACT. More to come on that. As mentioned, today's focus will be on the new ACT test, which stands for Audible Contrast Threshold, developed by Interacoustics. During today's session, you'll learn the requirements and benefits to both the patient and clinician of incorporating and using the ACT test, how to prepare for and complete the ACT test, again, both from the patient perspective and the provider perspective. And finally, how to interpret and utilize the ACT value to improve patient outcomes and provide value to both the patient and the provider. To learn this, we'll also spend a fair amount of time today reviewing the research that led to the development of ACT. On this slide, you can see a brief overview of our agenda for today. We'll start with discussing why ACT was developed. Audiometry is an important clinical tool, but there are aspects of hearing that the pure tone audiogram doesn't cover. Think about what information we don't get when performing pure tone audiometry. We get some information from pure tone audiometry, but not the whole picture. The audiogram doesn't tell us how the patient will perform in the real world. The ability to hear pure tones in quiet does not reflect the typical demands that everyday conversational situations impose. And using only pure tone audiometry to fit hearing aids is limited in the guidance we then have for advanced hearing aid feature settings. Finally, as many studies have shown, we know already that pure tone audiometry is a poor predictor of intelligibility. Speech audiometry is something that clinicians perform at times to supplement audiometry. Performing these tests provides the clinician with more information, and we can see and understand some of the reasons why speech audiometry is beneficial. It certainly has its place, and there are lots of studies to suggest speech and noise tests specifically can help supplement the patient rehabilitation process. Additionally, speech audiometry provides relatable material for the patient. It can help guide hearing aid management. It can be used during the counseling process, and more. Now, we can all agree why speech testing can be very beneficial, and there are plenty of articles suggesting why it should be done. But what exactly prevents some clinicians from doing it? We certainly know that in real-life situations, it can be difficult to include speech audiometry within our appointments despite the advantages of including it. Some of these obstacles are time, access to testing materials, objective and clear starting points for clear audibility for the patient, room setup, and more. So we know that the audiogram is vital. It's what's mandatory for hearing aid prescription targets, but we get no information about speech and noise abilities from the pure tone audiogram. Speech audiometry is a great addition to any consultation, but does have its limitations in some cases, and not everyone is doing it in any case. So what marries the two? What can give us accurate diagnostic information that takes us beyond the audiogram, that's unique to each patient and can address the number one concern reported by patients with hearing loss, hearing and noise? And this is where ACT comes into play. On the next few slides, we're going to walk through the typical patient workflow based on today's standards. We're typically starting with an audiogram, then moving on to advanced diagnostic tests when needed, such as the 10 test. Speech and quiet testing is often performed, SRT, word rec, MCL, UCL, etc. And at times, we're moving on to speech and noise tests like the Quicksin, ANL, things like that. These are great indicators for hearing aid acceptance, but they're not completely objective tests and can't be used automatically to adjust advanced features in hearing aids. And after that point, we're of course moving on to the hearing aid fitting when appropriate. So with the patient in mind, a gold standard consultation could look like this. In comes ACT, the accurate predictor of aided speech and noise performance, independent of language and easy to administer. The purpose of this workflow is to show what could be possible. You would still perform audiometry. It's a baseline requirement for ACT. ACT isn't replacing any part of a clinician's existing workflow if they don't want it to, but it can be used as a replacement for other speech and noise tests. It's a fast test designed to be used alongside your audiogram in order to make a comprehensive and customized fitting for your patient. Let's take a look back at the research that has led to the creation of ACT and the pathway from research to diagnostic implementation. To best understand ACT, we're going to take a journey from where it started to where we are now. We'll go through everything from the history of ACT, who the brains are behind the invention, what is the background evidence behind ACT that makes it accurate and reliable, and how did we create a user-friendly diagnostic implementation so it can be added to your existing workflow. So why ACT and why now? Because the only diagnostic measurement we currently use to program hearing aids is the audiogram, which is still extremely valuable. But as we've already discussed, hearing loss is so much more than the audiogram. There has been an ongoing search for diagnostic tests that take us to the next level beyond the audiogram, but no one was able to confidently and successfully create this yet. And ACT is about to change this. If we think of the audiogram as measuring the quantity of the hearing, ACT measures the quality of the hearing. We still have our audiogram and real-ear measurements, of course, that ensure the hearing aids are programmed appropriately for the hearing loss, acoustic parameters of the patient's ears, and more. But now we also have ACT, another tool in our toolkit that helps guide the programming of advanced help and noise features in hearing aids. These two, combined, provide you with the tools you need to get a complete diagnosis of your patient's hearing and a more objective and customized fitting. This has been a giant undertaking, and because of this, I want to make sure to give credit where it's due, to the collaborative team that was involved in the creation of ACT. We have had Interacoustics Research Unit heading up 7 years of research. The journey also involved Interacoustics for diagnostic implementation, Eric's Home Research Center, and CAR, the Center for Applied Audiology Research. Together, we developed ACT and transformed it into a unique automatic prescription. More to come on this, but for now, we'll move on to the research. So where did it all begin? It began in the 2010s when research saw a strong correlation between a test of something similar to ACT and speech and noise measures. This early version of ACT, as we now call it, is known as spectrotemporal modulation, or STM, and it's a psychoacoustic measure. STM is essentially an unmodulated sound with a modulated sound imposed on top of it. As an example of what STM is, we can see on the left a spectrogram of a single sentence. As you know, this shows characteristic patterns across frequency and time. These patterns are the same as in an early ACT or STM stimulus shown on the right. Modulations are imposed onto a noise signal, so you get a similar pattern as the speech spectrogram on the left, but in a more controlled and structured fashion. Let's hear some sound examples of this. First, you're going to hear the ACT stimulus. Next, you'll hear the reference noise or the steady noise. And finally, you'll hear the ACT stimulus imposed on top of the steady noise. If you're good at ACT, you can detect tiny modulations, which in essence means you're good at detecting the important speech cues when embedded in background noise. By manipulating the depth of the modulations and getting patients to detect these modulations, we can obtain a threshold or an ACT value from which we can infer how good someone will be at picking out the speech cues and noise. However, there were problems with this early version of ACT. A body of literature on STM was studied, and there was interest gained in this in 2013, where they were showing correlations between early versions of ACT against other speech and noise measures. The results from this more controlled, carefully recruited group of test subjects showed correlations were very high with beyond the audiogram measures. In 2016, a subsequent study, our early ACT test, was taken through a large study in Sweden, but 1/3 of the population couldn't do the test. They couldn't hear the modulations, which was very frustrating. For that 1/3 that failed, they had to modify the test paradigm so that they could get a measurement, which is where the data points come from on the slide. At this point, IRU really wanted to unleash the potential of this test and make it clinically viable as ACT as we know it today. So what modifications did IRU have to make to this early version of STM to make it clinically viable? As we've said, earlier versions of spectrotemporal modulation were not easy tests to administer. So let's take a closer look at what we had to do to unleash its full potential. The first change was to ensure that the stimulus was clearly audible to ensure that patients could actually do the test. In previous tests, we talked about how there was a ceiling effect where essentially 1/3 of the participants couldn't complete the test. The first modification was to add ear and frequency-specific compensation for hearing loss. In previous STM tests, in order to make the stimuli audible, they cranked the signal up, but IRU took a different approach. On this slide, you can see a graph showing gain compensation. Here's a closer-up image of that graph as we go through it. In the green line, you can see hearing thresholds of normal hearing people. In the black line, you can see the ACT stimulus played to someone as if they have normal hearing. You can see that across the frequency range, it's aligned with the natural speech levels, and everything is super threshold. Now, if we take a look at the red line, we have an audiogram of an individual with hearing loss. If we were to present the black stimulus to people with an audiogram that looks like the red line, they wouldn't hear the entire stimulus. The entire stimulus is not super threshold. And now you can see what IRU did differently in the pink bars, increasing the necessary frequencies by 15 dB sensation level to make them clearly audible and therefore following the shape of the audiogram. IRU ensured that the stimulus was clearly audible to fight the ceiling effect, particularly in older individuals due to cognition, etc. They also changed the test paradigm to a 3-alternative forced choice paradigm in order to make the differentiation between stimuli easier. In this test paradigm, one sound of the 3 presented was different, and the test subject was required to pick the odd one out, rather than in previous studies, they had to explain the difference between 2 presented stimuli. During this iteration, the modulation times were also increased from 0.5 seconds to 1 second. Finally, during these evaluations, IRU decided to go with a binaural stimulation instead of a monaural stimulation, increasing the ease and accuracy of the test, as well as improving the correspondence with real-world speech and noise listening situations. Next, they had to adjust the degree of spectral modulation and the bandwidth of the stimulus. To do this, the researchers needed to look at other speech and noise measures. In collaboration with Ericsson, IRU set up a test environment that imitated a real-world listening environment, but using loudspeakers. This study looked at ACT in relation to speech and noise measures, in this case, the hint. The hint was used since it can be set up in an ecologically valid fashion, again, simulating real-world listening situations. They found a high correlation between ACT values and hint scores, and all study participants were able to produce a threshold resolving the ceiling effect and reinforcing the relationship between ACT and speech and noise performance. To summarize what IRU completed until this point, they compensated for audibility, ensuring super threshold presentation. They changed the test paradigm to a 3 alternative forced choice. They extended the length of the modulations. They went from monaural to a binaural presentation. They ensured that the task and stimuli parameters provide reliable results across the board. And they ensured that the test has a high correlation to speech and noise testing performed in an ecologically valid fashion. At this point, we knew that ACT works, and we wanted to create a clinically viable tool. In order to do this, IRU conducted further research to ensure the test time was quick, there was no need for extra hardware, it used a familiar procedure that audiologists are used to, and the value it produces takes into account the best available data points for a more precise threshold determination. So after all this research, what makes ACT so special? We have a foundation for a better first fit. The ACT value has a strong correlation to predicted aided performance in noisy environments, the most common concern reported by patients with hearing loss. This value can help guide you on how to adjust advanced features on the hearing aids at the first fitting. For select hearing aids, the ACT value can be input into the hearing aid manufacturer software, and the adaptive features of that hearing aid can be automatically adjusted. It is the first ever language-independent diagnostic test of speech and noise ability. It's conducted in a very similar way to pure tone audiometry, using the modified Hughes and Westlake bracketing approach, but with 2 and 4 dB step sizes instead of 5 and 10, making it an easy test to perform for both the patient and clinician. Other speech and noise tests can take significantly more time than ACT, which takes on average 2 minutes. And we have a novel way of denoting the ACT value, the NCL scale, which was created in order for us to understand how ACT values compare to normal hearing listeners. Now let's take a look at the ACT software and how we perform it. I'll show you what it looks like today using the Interacoustics Affinity Compact. This is a close-up of the ACT software screen. You can see the presentation numbers on the x-axis and the ACT value in dB/NCL on the y-axis. There's a line at 25 presentations because this is where you begin to risk patient fatigue. In order to avoid hitting or going over 25 presentations, it's very important not to time lock the patient during testing. Channel 1 and Channel 2 presentation levels will be predetermined based on the audiogram, and one channel will be routed to each ear. The test will always start at 16 dB NCL, which you can see in the top center of the screen. And as the NCL value decreases, the modulation is more difficult to detect. On this next screen, you can see a completed ACT test. When the clinician introduces the modulation, the software will automatically determine if the patient responded or not based on the timing of the presentation and the patient response. A correct response will show as a black filled-in circle, and an outline circle is a miss. In the top right-hand corner, you'll be able to see false alarms. Every time the patient correctly responds, the clinician will make it 4 dB more difficult, or 2 steps. And when the patient misses it, the clinician will make it 2 dB easier, or 1 step. Again, following the modified Hughes and Westlake bracketing approach, but using 2 and 4 dB step sizes instead of 5 and 10. Note that the clinician is not adjusting the intensity of channels 1 or 2, but rather the difference between the modulated signal and the base noise. When the patient responds correctly at the same intensity 3 of 5 times on an ascending trial, the software will automatically stop you and provide you with the ACT value. Once you have the ACT value, you can click on Guidance to see the ACT value ranges and fitting advice. We'll take a look at those in just a moment. With all this information on ACT, we'll spend a bit of time talking about how you can go about using the result. Generally speaking, the greater the ACT value, the more help one will need from the hearing aids and noise. You can use the ACT value in one of 2 ways. If the hearing aid manufacturer supports it, you can use an automatic function, and the value of the ACT will be transferred into the hearing aid manufacturer software to determine the level that the adaptive features should be set at. These changes can be made again automatically through the hearing aid manufacturer software. However, in some cases, if that isn't an option, you can use the guidance that we provide. You can see from the scale that the ACT value will fall into one of 4 categories, ranging from normal to severe. The lower the number, the smaller of a modulation the patient was able to detect. Again, if someone has a lower ACT value, that means they're able to detect even smaller modulations. So the recommendation for these patients is to pull back on those advanced help and noise features. Those patients are doing just fine at detecting speech and noise without extra help. On the other hand, with a higher ACT value, you'll want to do the opposite and increase those advanced features. Perhaps recommend some additional accessories for that patient from the very beginning. If we think about fittings as they exist today, 2 patients with the same audiogram, same age, etc., would likely leave an office with the same help and noise settings. With the introduction of ACT, we can now be confident on when we want to pull down on some of those advanced adaptive features, and perhaps crank these features up for some patients, meaning 2 people of the same age with the same audiogram will leave the clinic with 2 different and customized fitting setups from the very beginning, which in turn will improve the first fitting. In summary, we know that ACT, or the Audible Contrast Threshold test, is a clinically viable test of spectrotemporal modulation detection. It uses the audiogram to individually shape and customize the stimulus to ensure full audibility across the frequency range. ACT is a measure of an individual's aided predicted speech and noise performance using hearing aids in realistic conditions. It is a fast and simple test. It takes on average 2 minutes. It can be done immediately after the audiogram. And it is a language-independent test, meaning it can be done on every patient, irrespective of their language background. If a patient is able to follow pure tone audiometry instructions, they'll be able to follow ACT instructions. Expected outcomes when using ACT are to provide you with confidence when you're prescribing or adjusting those advanced help and noise features on hearing aids. Improved patient outcomes in noisy situations, reduced follow-up visits, reduced in-the-drawer hearing aids, and we're very excited about the more research that we'll be able to share as it becomes available on the ACT test. Thank you for taking the time to join today. If you're interested in learning more about ACT and you're in the United States, please contact your local E3 diagnostic sales representative. For those outside the U.S., please reach out to Interacoustic directly at info@interacoustics.com as shown on the slide. Thank you.